So thank you for that introduction. I appreciate it. I am originally from Franklin. I did go to BGA. I grew up in the area. I left the area. I've been gone for a long time. But I just recently got back, and I'm the newest member of the Vanderbilt Bone and Joint in Franklin. And I got to join some guys I grew up who took care of me, like the late Craig Farrell and Paul Thomas and Paul Parsons and Dr. Bratton and a lot of guys that y'all might know from the community. So it's my pleasure to be back. But as the new guy, they say, hey, we got a lecture for you and I want you to go do it. And I said, okay, I'm happy to go. And I didn't know anything about the Osher lecture series, but I looked it up and it's pretty impressive. And it's really impressive to see so many people here and so many people interested in lifelong learning, which is something that you do as a doctor. You just have to be involved in lifelong learning or you get left behind. And this is a little bit about that because we're going to talk about the evolving trends. Thanks so much. And so this would be forward. Good. So we're going to talk about the evolving trends in hip and knee arthroplasty surgery. And so this is all my affiliations. This is undergraduate in engineering at Knoxville, and then I went to the University of Tennessee for medical school, and I got the privilege of staying there at Campbell Clinic, which is a wonderful orthopedic institute. And then I did my fellowship at the Anderson Orthopedic Institute in Alexandria, Virginia. That's where they really began the notion of utilizing non-cemented techniques for the hip arthroplasty. So in the knees, we still cement everything. We cement the metal components into the bones. But in the hips, largely in America, we do a press fit technique where there's a porous metal on the outside of the bone. We shape the bone slightly smaller than the size of the implant, and then we place the implant into the body to where it's in a nice stable position. And over the course of the next 6 weeks, your bone grows into the porous metal of the implant, and it becomes a composite construct that's a part of you. And here we're having a lot of success with it in the United States. In England, they still use cemented hips, and they use it quite often, and they do a good job with it, but we find it more successful to be press fit. And then my new affiliation. So these are the three things we're going to talk about today. We're going to talk about the anterior total hip arthroplasty, the partial knee replacement, and then what we're calling accelerated recovery programs, which is probably the newest and most important trend. So a little bit about my philosophy as a physician. Things have changed probably a lot through your lifetime with how physicians interact with their patients. And definitely things have changed with my generation of upcoming physicians. We no longer tell you what you should do. We no longer just say, I'm right and you're wrong, and I'm smart and you're not, and I've studied for a long time, and you don't know any of these words, so you do what I tell you to do. Our main goal now is to educate you to your options and to tell you the risk stratification of your options. And so I consider myself an educator, and I consider myself a risk manager of your health in an orthopedic fashion. And particularly in orthopedics, most things are elective, meaning you don't have to have it done. You can live with your pain. You can live with your deformity. You can live with your poor range of motion of your joint. It's not going to kill you. It's not a heart attack. You know, it's not cancer. It's arthritis for the most part, or it's a broken bone. So it's elective. So it's your choice to undergo the surgery. Well, if anything that's elective means that you need to understand the risk that you're taking in order to undergo that procedure. And so that's the biggest thing. The other thing is a team-based approach to care. My wife's a physical therapist, and she really is the reason why I got so involved in the concept of team-based approach to care, because I realized that she is so much smarter than me in so many ways. And as a surgeon, when you're going through all your training, you have to develop this ego where you feel smarter than everyone else, even though you're not. And I think it's that way so that you feel comfortable and confident with making an incision on someone and dissecting down and basically operating on them and then closing them up and then going and doing it to the next person. And so there has to be a level of confidence for you to do that every day. But she knows a fortune about rehabilitation. She knows a fortune about the natural kinematics and function of the human body. And so a team-based approach to medicine means that the nursing staff has to be very good, and they have to care a lot about the side effects of the drugs they're given. They have to give efficient drugs. They have to give it appropriately in the appropriate times. The physical therapists have to be very involved. And all these things have to occur in unison for you to have success with your surgery. So I'm not going to go a lot into this. What drives medical trends? Well, I'm an optimist. I hope that patient care drives medical trends. I hope that patient outcomes or failures change and develop how we do things. But a lot of people would say money, and say money for everything, such as marketing. And in America, we have direct-to-consumer marketing, so you probably see advertisement online for the new get-around knee, or the gender-specific knee, or the lawyer saying, call me if you had a metal-on-metal hip replacement, or a lot of different things that probably drive the market quite a bit. And that's legal here. It's not legal in a lot of other countries, but I choose to believe that patient outcomes should be the main driving force and are the main driving force. So the first thing we're going to talk about is the anterior total hip arthroplasty. And so in order to do that, we have to have a little bit of a lecture because we all have to be on the same page with what we're talking about. And the first thing we need to define is minimally invasive surgery. You hear this word a lot, minimally invasive. It was minimally invasive. I had it and it was wonderful. And the reality is there's no definition of minimally invasive surgery. This is a very nebulous term thrown around by a lot of people, and it's mostly marketing. And it's mostly to try to tell you that what I'm doing is in your best interest and it's the smallest thing I could do for your problem. But are there actually procedures that are less invasive? And so I use the word less invasive because I think it's not as nebulous. And it basically says that if you compare two things relative to each other, there might be one that's less invasive. And I believe that the anterior hip replacement is less invasive than some of the traditional approaches. Doesn't make it better always, but I believe that it's better, and I believe that it's less invasive. The partial knee arthroplasty is less invasive than a total knee arthroplasty, and we'll go through that. Anterior hip replacement. So first, this is a total hip. Okay, these are the components separated from each other. This is a femoral stem. It goes inside the canal of the femur. The head and neck are here. This is the cup. This replaces the portion on the side of your pelvis. And then between the two goes some type of a liner. And the most likely liner is a piece of plastic called polyethylene. There are a lot of different bearing surfaces. There's metal on metal. There is metal on ceramic. There's ceramic on ceramic. There's ceramic on plastic. There's metal on plastic. There's a lot of them. The most common is metal on plastic. Okay, and we won't get into the bearing conversation about metal on metal. If you've heard anything about that, we'll kind of focus on some other things for today. But so back to our lesson. We call this osteology, the study of bones. This is your spine. It comes down into your sacrum. Very, very strong ligaments attach the sacrum as well as the lower lumbar spine to the pelvis. The pelvis then transmit the forces of the upper extremities, the body, the axial skeleton into the hips. And so the hip is a ball and socket joint. This is your femur. We'll call this the femur or the shaft. We'll call the connection between the head and the shaft the neck. And we'll call this circular area the head. And then we're going to call the acetabulum, which is the socket portion of the ball and socket, we'll call that the cup. So this is a normal hip, and this is an abnormal hip. So we have to understand a little bit about the hip in order to be able to have this discussion. And so this is a closed system. So at the end of bones, there's articular cartilage. It's a soft cartilage that is drawn here in white, and it's on both surfaces. It dissipates force. It allows for very smooth, non-frictionless motion. Wrapped around here, that's not depicted in the picture, a very strong capsular structure, like a balloon around the joint, that holds in all the fluid of the joint. It's a fluid-filled system, a hydraulic system. And when the synovial fluid is normal and functioning well, it's almost a frictionless surface. So contrast that with arthritis, and we won't go into why you get arthritis because that's really a whole other discussion, but it's mostly genetic, or you can have inflammatory, you can have a disease process, or you can have subtle changes in your bony structure your whole life congenitally that could lead to it. But for one reason or the other, you get arthritis, and what you see is it's the breakdown of this smooth white cartilage. And so you develop exposed bone. You developed an inflammatory process. It increases your pain, and it causes a range of things that we're going to talk about. But when you never see this, this is a drawing, what you see is this. This is how we look at arthritis in the body. We take an x-ray. It's the quickest and cheapest way to do it. So on the left side here, you see that this patient has no arthritis, and on the right side, I think you can appreciate that this is arthritis. But we're going to talk about kind of the four main criteria that we see as doctors to determine whether the patient has arthritis, and the first one is joint space narrowing. You say, well, what is joint space narrowing? Well, it's a radiographic finding. It's a finding on x-ray. So this patient is standing. And so if they're standing, it looks like this circular head and this cup are separated by this space. They're not separated. They're touching each other. The patient's standing. The patient's transmitting force through the pelvis into the legs. But cartilage is radiolucent, so you don't see it on x-ray. Bone is radio-opaque. You see it on x-ray. So the space is cartilage. There's no space over here. Minimal space right there. All that cartilage is gone. That's the first criteria. Number two, we look at osteophytes. We commonly call them bone spurs. People say, I have a bone spur. The bone spur's hurting me. The bone spur is probably not hurting you. The bone spur is a reaction to a process. The bone spur is not the problem. If we get rid of the bone spurs, you'll still have a major problem. But the bone spur is a reaction to the problem. So bone's a living tissue. It's a very hard living tissue, but it's alive. And what it does is it responds to force. And so when the force is increased to the bone, because the articular cartilage has been worn down, it's like wearing down the tires on your car, your rims see more force. And so the bone does the only thing it knows how to do, it grows more bone. And it grows it aberrantly in areas where it's not supposed to grow bone. And that's what a bone spur is in relation to osteoarthritis, And the next criteria is sclerosis. So if you look at this bone, it looks like the bone is nice, uniform color. Ignore these lines because that's the back of the pelvis that you see through the head of the femur. But this bone looks like a nice, normal color. If you look over here, there's a lot of white everywhere. That's increased mineralization of the bone. We call it sclerosis. The bone is reacting to the increased force that it's seeing, and it's hardening. And so it looks more white on x-ray. And then the last thing we look for is cystic changes or erosions. So this side of the healthy hip is circular. This is no longer circular. It's lost its normal shape. It's starting to erode. It's starting to change. Why is it changing? Well, a couple reasons. When you lose the cartilage, you expose the bone to the hydraulic system. Bone is like coral. It's porous. So if you have a closed hydraulic system that's constantly pistoning fluid in and out of a porous material, it creates cysts. It slowly erodes it. And then when the bones start to rub on the bones, well, that's mechanical erosion. It just slowly starts to wear away the bone. So that's the four cardinal signs of arthritis. That's the same for the knee. Okay? This is pretty much what arthritis looks like in every joint in the body. And so now you'll know it on x-ray when you see it on x-ray. So this is what a total hip arthroplasty looks like, regardless of how you do it. Femoral stem. The first thing you do is you make a cut at the femoral neck and you remove the head and the neck. And then you prepare the inside of the bone to be slightly smaller than the stem that you're implanting. And we implant the stem. And we literally mallet it into the bone. This is the artificial cup. The artificial cup, the surface to prepare the bone for the artificial cup is actually a reamer. It looks like a little bit of a cheese grater. It's hemispherical. And we put it into the pelvis and recreate the bone to be slightly smaller than the shape of that cup. We then mallet that cup into your bone, and it press fits. We talked about it not cementing, but press fit. And then over time, the porous material on the outside of these surfaces will allow bone to grow into them. And then we place the head on the end of the femur, and inside here is a liner, most likely polyethylene. So those are the four components, again, separated. So what is an anterior hip? Well, anterior hip it's just an approach. So let's define the word approach. Approach is how a surgeon gets to where they need to go in order to do the job they need to do. Where do they make their incision? And there are places you can do approaches and places you can't do approaches. So you don't want to do an approach over a major nerve. Right? That would be a bad idea. That would put you at high risk for causing an injury. So there's been approaches to the hip that have been developed over time. And probably the most common one is the posterior approach, the incision on the buttock area. And I would say the second most common, until the anterior hip started to become more popular, is the direct lateral or the anterior lateral. And that's an incision more on the side of the hip. So just to review anatomic positioning, this is the front, we call it anterior. This is the side, we call it lateral. This is the back, we call it posterior. Okay? So what the direct anterior is, it's an approach to the hip. So here is a schematic of a posterior approach and anterior lateral approach. And this, you have to forgive me because it looks like I'm trying to say something negative about the posterior approach. I'm not. I do use the posterior approach, and this is more of an anatomic picture to describe what we do in the posterior approach. But you do not cut the gluteus maximus tendon in the posterior approach. Okay? You split it, and you split it along the fibers. But you do cut these muscles, and these are the muscles that connect to the posterior portion of the femur. And you cut those so that you can dislocate the femur. You can remove the femur from the socket so that you can work and that you can remove the head of the femur. Okay? So an incision for a posterior approach would be somewhere around here over the skin. So this is a lateral approach. This is the head this direction, this is the leg this direction, this is the buttock, and this is up. So this is the front of your body, and this is an incision directly along the side of your hip. A lateral or anterior lateral approach normally makes an incision actually through this muscle right here called the abductor, and then elevates that muscle off the bone, and once you do that, you will be inside and able to do your work inside the hip. So the anterior hip approach is different because we don't cut any major muscle groups. In order to get to the hip, we utilize a normal plane that is both what we call internervous and intermuscular. Okay? I'm going to tell you what those mean. But the incision is made on the front of the hip rather than on the back or the side, and it basically allows us to work to get to the hip without detaching the muscles. And so this is the plane we use. The approach is not new. It's been around for a long time. It's used in pediatric surgery very often. It's been used in hip replacement surgery in the past. It was very popular in France. And now that I come back to this practice, I talk to some of my older partners, and they say, yeah, we used to do that approach a long time ago. We gave that up. So you think, well, why do these trends become cyclical? Why do they come back? And we'll get into that when we get into the accelerated recovery program, but I think they become cyclical because our goals change. And right now, one of the primary goals in healthcare is how do we pay for all this? And how do we do all this and supply the appropriate care to patients and at the same time do it in the most efficient manner? And when you used to get a total knee replacement or a total hip replacement, you would go to the hospital a day or two before. You would stay probably 5 days after, and then you would go to an inpatient rehab facility for maybe 2 weeks or more. And all of that is extremely expensive. And what we're doing is we're trying to find more effective methods to have you return to function as quickly as possible in the most efficient manner as possible. And the outcome of this is outpatient total joint surgery. And so how you go from hospital admission 2 days before, 5 days hospitalization, inpatient rehab 2 weeks, to outpatient total joint surgery is pretty phenomenal. But it happens in multiple ways, and we're going to talk about how it happens. Okay, so returning to the anterior approach, this is the idea of the internervous and intermuscular plane. Some of you might have a background in anatomy, might know some of this, some might not. But basically what this means is we go between muscles, and the muscles we go between are supplied by two different nerves. And so the odds of doing damage is greatly decreased. If you go between two muscles that are supplied by the same nerve, then there's a potential to damage the nerve or the muscle in such a way that the muscle quits functioning. It becomes de-innervated. It's no longer innervated by the nerve. It's no longer supplying its appropriate function. So this is a slightly safer approach. This is a patient laying on an operative table. This is their legs. Their head is up here towards this portion. This is their pelvis. We have draped them out here in a sterile fashion, and you can see that the incision is being made right there. Okay? So the incision is not here for the anterior approach. It's actually here, because this is where your hip is. Your hip's here, not here. So if we took a cross-section of what we're doing, this would be your hip in cross-section, this would be your pelvis, these are all your muscle bellies. So this is a section through the body in this direction, and then you're looking at that section. And these arrows depict the anterior approach. And what you're doing is you see these arrows are sliding between these muscle bellies. And they're not cutting any of these muscle bellies until you get down here in the hip. One important caveat is that if any surgeon says, I don't cut the muscle when I do this, they might be saying that for clarification, but it's not 100% true. You can't get to the hip without cutting some muscle. Okay? It's impossible. It's completely surrounded by muscle. And once you get there, you can't put your components in without cutting some muscle. So even though I do this from the front, I actually do cut some small tendons in the back in order to put this prosthesis in. But the important thing is I don't cut out all the ligaments in the capsule in the back. Okay? And we'll get to why that's important. So this is what it looks like from the front once you've moved all the muscles out of the way and you're staring at the hip. This is the hip, and this white stuff over the top is the capsule. And this is a good depiction of what it actually looks like in surgery. And you can see how superficial it is. Your hip is not too deep to just you're touching your skin right here. Whereas from the back, you feel all of your gluteus maximus and you feel some adipose tissue back there. And your hip is deep to that. Some more than others, I know. Okay, so I believe the anterior approach to the total hip is probably the most muscle-sparing approach. It's not completely muscle-sparing, but probably the most muscle-sparing approach. And most importantly, you don't touch the abductor muscle, which is the muscle that you cut when I showed you that picture on the side, okay, because that has a very important role of holding the hip in place. And you don't cut the posterior capsule, another structure that is very important to preventing the hip from coming out of socket or dislocating. So most importantly, if you're not doing as much damage to the muscles around you, you're hopefully not getting as much inflammation, you're not getting as much pain, and I believe because of this, you have a greater opportunity for a faster recovery, quicker return to function, and less postoperative pain. It doesn't mean that everyone does. It means that you have a greater opportunity. So when we do this approach, there's two camps. Some use a table, some don't use a table. I don't think it matters. Where I trained, one guy used a table, one guy didn't use a table. I thought they both did a very good job. I don't think you have to have the special table to do this. I use the special table to do this because I find it very comfortable and convenient to be able to control the leg in a very nice, smooth fashion. And basically, if I have the patient set up in this table, I need less people in the room to help me. So there's less people, there's less, we'll just say there's less people. I'd say less chaos, but there's never really chaos in the, there's no chaos in an operating room, but you know, the more people there are, the more moving parts there are, and I like having less moving parts and a little more control of the operating room.
Is that less cost as well?
I'm sorry?
Less cost as well?
This is a very expensive table. This is a $100,000 table. So this is a big hit for hospitals to purchase this, and they have to have a desire to do so. So we purchased this at Williamson Medical Center because they bought into the idea that I was going to be doing the anterior approach. One of my partners has begun doing the anterior approach, and that they believe it's going to be successful. But there are many hospitals who can't afford to put $100,000 on a table just to help get the anterior approach going, if that makes sense. So what are the benefits of the anterior approach? And some of this is subjective, and as you move down the line, it becomes more objective. Okay? So less activity restrictions after surgery. You have all some of you have probably had a hip replacement. Some of you definitely know friends who have had hip replacements. If you ever talk to them about it, a lot of them say, well, I wasn't allowed to tie my shoe afterwards. I had to sit on an elevated commode. I had to sleep with a pillow between my legs. I had all these restrictions for a good 6 weeks, maybe to even 3 months. Those restrictions don't exist with an anterior hip replacement. So functionally, you get back to activity a little quicker. You can sit on a normal toilet. You can put your shoes on. You can sit and stand in a normal fashion without being scared that you're going to dislocate your hip. Because we did not make an incision on the back, we did not remove that capsule, we did not disrupt that muscle, and the odds of you having a dislocation are extremely low. Okay? That's probably the number one advantage for me of the anterior total hip, is the dislocation rate is much lower. Another advantage that's not on this slide, maybe I should have put it on the slide, but it becomes a little more technical, is that I take x-ray in surgery. So I know where I put my components before the patient wakes up and leaves the operating room. Traditionally, when the patient is getting a posterior or even a lateral approach, they are usually on their side. And laying on your side, your pelvis has a tendency to tilt in one way or the other. And it's very hard to get a good x-ray. And a lot of surgeons don't get an x-ray with that approach. Some do, but a lot don't. And so they don't actually know 100% where they put your components until you're awake and in the recovery room, and they take an x-ray in the recovery room. I find that to be a great advantage because I can instantly know if I don't like where I put the components, and where you put the components matter. Where you put that cup. You put it too far this way, too far that way, too far towards yourself, too far away from yourself. All that matters. And so that's another positive for me about the hip. And then these, less pain, quicker recovery, less muscle damage, these are things that a lot of the posterior approach doctors might argue with us over, and we'll argue about that. But I feel that this is probably the case. I've trained on both, and I still use the posterior approach. I use it for revision work. Define revision, it means any time we have to redo surgery. Okay? If we have to redo surgery on someone, I tend to use the posterior approach because it's a larger visual field of everything that you need to do, is the reason why I do that. This is a hip dislocation. A lot of patients say, well, how would I know if I dislocate my hip? And I just say, you're going to know. Don't worry about it. Like, you don't even have to think about it. Go about your business. If you dislocate your hip, there won't be a doubt in your mind that your hip's dislocated. And this is what it looks like when it comes in. And the vast majority of dislocations are posterior. Why are they posterior? Well, you might argue they're posterior because most approaches done today are posterior approaches. But the other major reason is because all functional activity that we do tends to push our hip out the back. So a posterior approach dislocation position includes deep squatting, or rising from a seated position, or crossing one leg over the other. And we all do that fairly often. Well, an anterior hip dislocation position is extension and external rotation. And we don't all do that every day. You might do it some yoga or something like that, but you don't really do that every day. A posterior approach surgeon will argue, yeah, but you can do that if you step away from your leg. If this is my hip I've operated on and I step away from my leg, could I dislocate out the front? Yes, you could. You could. But statistically, good data has shown that the odds of dislocating with an anterior hip replacement is 1% or less. And the odds of dislocating with a posterior approach varies quite a bit, between 3 and 8%, depending on the study you look at. So potential negatives. It's more challenging for the surgeon. There's no way around that the anterior hip replacement is a more challenging procedure. Has a higher learning curve. It is more difficult to get the femoral component in, okay, the stem. And so a lot of surgeons don't like to do it because it's more challenging. The second reason is because there is increased blood loss on most studies. You say, well, why would there be increased blood loss for a less invasive surgery? That doesn't make sense. It's very counterintuitive. Well, there's a couple reasons, I think. Number one, because you're not doing such a large exposure to see what you're operating on, there can be small, subtle bleeders somewhere that you didn't see. Okay? Because when we see something bleeding in surgery, we stop it from bleeding. The other reason is this area is heavily vascularized. A little more so than this area. But this is probably something, in my opinion, that as anterior hip replacement gets more popular, will decrease in difference between a posterior approach. I think it's a little bit of a learning curve that we're all going through. And this is probably, although I can't give you the numbers on this, not as important in terms of transfusion rate. Okay? So I haven't personally seen something that says an anterior hip has a higher transfusion rate. And that's really what matters. Whether your hemoglobin is 9.7 or 9.3 is probably less important than whether or not you require a blood transfusion for symptoms of a low hemoglobin. And I don't know of any studies showing that there's a difference in that. So, increased wound issues. There is a small increase in wound issues because anywhere you look at your body, the flexor surface has more pliable, less strong skin than the extensor surface. So the inside of the elbow, if you ever look at that, you can kind of see your veins. It's a little more thin of skin than the outside. The back of the knee compared to the front of the knee. The inside of the hip compared to the buttock. So that skin is not used to as much wear and tear. And for that reason, and because the hip is more superficial in this direction. So if you have a lot of bruising after surgery with an anterior hip replacement in this area, that's not too uncommon. You can have bruising from the back as well. But from the back, you have a lot of tissue planes to hold that bruising in to where you may never see it. In the front, there's less tissue planes, so you might see it a little more often. And then the last negative of an anterior hip replacement is there's a small nerve to the thigh right here, and it's cutaneous. It's just sensory. And about 2% of the time, it's damaged in such a way that it might cause some numbness and tingling in this area. Okay? The vast majority of the time that it's damaged, it returns to normal function within 6 months or so. But it's usually a stretch injury. So in order to push everything apart without cutting everything, we actually have to slightly stretch things. And so that could occur. These are all pretty rare. But they do occur, and it's important to point out positives and negatives of any approach that you're going to do. So, you know, who's a candidate for this type of approach? In my practice, everyone's a candidate. So, you know, 99% of primary hip replacements I do anterior, and then the other percent is something special. Either have pre-existing hardware because it was a hip fracture, or they have some type of congenital abnormality like dysplasia of the hip. You might have heard that word before, meaning that the bones are shaped differently. That would be an instant where I might not use this particular approach. Otherwise, I tend to use this approach in all those settings. Okay, so let's move on to partial knee replacement. What's a partial knee replacement? So this is a partial knee replacement. It has three components. It has a component that goes over the femur. This is your femur. This is your tibia. Your tibia is also known as your shin bone. These two articulate with each other. Remember, there's cartilage in between here. And then there's two meniscal pads. So those are two separate things. There's cartilage that overlies the bone, and then there's two meniscus, which is a type of cartilage as well, and they're padding between the bones. So this resurfaces the femur. This tibial tray sits here, and between the two is a piece of plastic. And look, on X-ray it looks like there's space, but there's actually plastic there, and that polyethylene is radiolucent, so you don't see it. So let's talk a little bit about knee osteoarthritis. What do we see here? We see joint space narrowing, we see sclerosis, we see bony erosion or cystic changes, and we see maybe a little osteophyte here. This patient's not forming a lot of osteophyte. And then if you look over here, we see good joint space. Okay? So you're thinking, you know, abnormal, normal. Well, I tricked you a little bit because this is the same knee. This knee is the same. What this is a stress radiograph. This is one of the ways we determine whether or not you're a candidate for a partial knee replacement. So this is a weight-bearing film, and these two bones are now touching each other. The articular cartilage is worn off enough that the bones are now resting on each other. They're grinding against each other. It's painful. It increases inflammation. If I take you to an X-ray suite and I place a stress on your knee, intentionally trying to open this space, this is what your knee looks like. And this is all the cartilage that you lost. So everything between here disappeared and became this. The good part about this is that this says that you have cartilage here. This didn't collapse. This stayed open. I'm intentionally trying to collapse it. It won't collapse. It won't collapse because you have good articular cartilage here. And this patient is more than likely a good candidate for a partial knee replacement instead of a total knee replacement. What's a total knee replacement? This is a total knee replacement. It's an excellent surgery for the right person. It resurfaces the femoral portion of the knee. It puts a tray at the top of the tibial portion, and between the two is a piece of plastic. Looks very similar to the partial knee. It is very similar. The partial knee was based upon it. Okay? People always want to know the metallurgy, so I'll just go ahead and tell you. This is cobalt chrome, polyethylene plastic, and this is titanium on most systems. Yes, sir?
So when you're doing either a hip or a knee, how do you precisely measure these such that you don't have people limping around with one leg shorter than the other?
So you don't lengthen through the knee. Okay? We don't lengthen or shorten people through the knee. We lengthen or shorten them through their hip. That's possible. You don't really do it through the knee. So what we do is before you go to surgery, you'll probably go back to the x-ray suite and you'll have special radiographs taken. We then take those x-rays and we know the magnification of those x-rays, and we have pre-templated either cellophane sheets or electronic. Okay? And we electronically put the component sizes and measure which size is going to fit you. It doesn't mean it's the size that's going to fit you, it's the size we think is going to fit you. We can measure, I'll have to go back to a picture of the hip, but you can measure the hip length discrepancy. Okay? So, as one hip starts to erode, it shortens. So the goal is to normalize it back to the hip length on the other side. And we can measure that. We can measure how much we want to increase your leg length. And X-ray is the best way to measure it. You'll have some people lay you down, they'll grab your legs, they'll pull you towards them, they'll grab the inside of your ankles, and they'll say, oh yeah, you're a centimeter and a half short. There's no good data saying that works. Because that implies that when they did that, your pelvis was perfectly neutral. And we don't know that your pelvis was neutral when we did that. So if your pelvis was tilted, then it would make you look shorter or longer, depending on which way you were lying on the table. So we pre-plan all of this. And then when we're in surgery, we check things. And this is another reason why I love my anterior approach for x-ray purposes. I know the leg length on the patient before they leave the room. It's not let's get an x-ray and recovery and see how we did on our leg lengths. I know what it is. I know if it's too long, I know if it's too short. I change it while I'm in there. And and leg length discrepancy is one of the biggest complaints that patients have, and they'll come in and they'll be extremely happy with their hip, but they'll say, my hip feels long, my leg feels longer. And that's something you need to know, that your leg might not be the same length, as it won't be the same length it was before, but it could be a little long, or it might still be a little short. Does that answer everything? Okay. All right, so that's the difference between the two. Okay. Let's talk about demographics. 620,000 patients undergo total knee replacement in the United States annually at this time. The prevalence of the population walking around with a total knee replacement is over 4 million patients. Okay? If we use our classic indications for partial knee replacement, only about 10% of these patients qualify for a partial knee replacement. Okay? What does that mean? We use the word indications as surgeons to say, what surgery am I going to utilize on a patient to give them their best results? Their indications for that surgery are things like this. This is the very classic indications for a partial knee replacement. I mean, it's 11 things. If you read through it, it's real detailed. You can't have this angle, you can't have that angle. It gets very cumbersome. And if you did a partial knee replacement on a patient with all of these indications, they're going to be very successful, and there's plenty of data to show that. But what we're finding is we're increasing these indications. We're decreasing the number of these indications. We're expanding our indications. I want to make sure I'm saying that correctly. We're expanding the amount of people who might be acceptable to do a partial knee replacement on. So I skipped this slide. Well, why are the numbers growing? Well, they're growing. Aging baby boomer population, post-World War II, a lot of babies were born somewhere between 46 and 64, and now we're all 65 or older, and it's a very large population of patients, and therefore it increases our numbers right away. Our life expectancy is increasing, and there is no age at which you don't qualify for an arthroplasty as long as you are healthy and can undergo the surgery. Yes, ma'am? low demand activity. This is also a very nebulous term. So the original indications basically said we don't want a person with really high demand because they might fail. This fell off. We no longer use that. What I'll get to once we finish the numbers section, because I got a little ahead of myself, is this is our current indications for a partial knee replacement. And I would actually argue that a high demand patient is the patient you want to consider a partial knee replacement in. Okay? So other reasons why the numbers are growing, we're decreasing the age at which we utilize the procedure. You know, we're a society where we don't like our lifestyle changed. We want to continue to do the things we want to do, and if we can't do them, we're going to go ask the doctor if there's any way we can continue doing that. And it used to be that the doctor would say, well, you need a replacement surgery, and we're not going to do that until you're 85, you can't walk, and you're miserable. And that's not what we say anymore. What we do is we go back to the first slide where we educate you and we tell you the risks and benefits. And then we decide together if you've reached a point, both in your symptoms and in your x-rays, and clinically on inspection of the knee, to whether or not you would benefit from a knee replacement. And so the age is getting younger and younger because we're putting them in younger and younger patients because we think they're beneficial to them. This is argumentative. Does our increasing obesity in our population increase our arthritis? Some people believe yes. There's a couple studies say no. But most importantly, some of the estimates coming out say that in the next 20 years, the number of total knee this TKAs is total knee arthroplasty, okay? Total knee. So estimates saying that the number of total knees that we do in 2030 will increase 673%. So this slide, I don't really want you to think about this in detail. I just want to show you how specific we used to be doing this surgery. And now this is what we think of. Does the patient have one compartment disease, either on the inside or the outside of the knee? Well, what's compartment disease? What I mean by that is, these are compartments. We consider the knee joint to have three compartments. The inside, the outside, we call it medial on the inside, we call it lateral on the outside, and then the compartment between the kneecap and the end of the femur we call the patellofemoral joint. Okay? So our new indications are one compartment disease, functional range of motion of the knee. How do we define functional? Well, it needs to be at least greater than 90, and I would like to see it somewhere around 100 to 105. Angular deformity greater than 15 degrees, that's passively correctable, might be somebody that you consider not doing a partial knee on because it's too much deformity to correct with a partial knee. There's plenty of people who would argue against this and say, no, you can still do the surgery on this patient. No severe patellofemoral arthritis. That means that you can have arthritis in your kneecap and still have a successful partial knee replacement. Most all studies are showing this. And that even if your arthritis in your kneecap worsens on x-ray, it doesn't actually worsen your clinical condition. And what that means is that the vast majority of your pain actually comes from the articulation between the thigh bone and the shin bone, the femur and the tibia, not the kneecap. Now, if your kneecap arthritis is extremely severe, bone on bone, then you might not be a candidate for a partial knee replacement. And then these are still argumentative. Does the ACL matter? That's the ligament in the middle of the knee. There's two. There's the ACL, PCL. They cross. They're called cruciate ligaments because they cross in the middle of the knee. Everyone's heard of an ACL injury in an athlete, and we go and we fix them, etc. Does an ACL, because a lot of us as we get older, we don't have an ACL anymore. It's kind of worn away or it's torn over time. Does it matter? Does it need to be intact? I think most studies say it doesn't need to be intact as long as you're using a particular implant. Okay? Because there's two types of partial knee replacements, and we're not going to get into this in detail, but there is a fixed bearing and a mobile bearing. And that has to do with the piece of plastic between the two pieces of metal. If it's fixed bearing, the plastic is locked into the tray. If it's mobile bearing, the plastic freely slides in between the two pieces of metal. I use a fixed bearing because the mobile bearings in every study that has ever been done have dislocated, and fixed bearings don't dislocate. And I think that we need to get rid of that particular failure mechanism. Although doctors who do mobile bearing knees well do them very well. And there are many, many patients out there with mobile bearing partial knees who are very, very happy. It's just not what I do. And then obesity. Is obesity, particularly really high obesity, does it exclude you from a partial knee replacement? And I would say obesity in itself doesn't, but very, very high obesity might. It really might. And the data is still out on all of these. So if we apply these new expanded criteria for a partial knee replacement, that would take that population we discussed and that would increase the number of people that we could do a partial knee replacement on from 10% to somewhere around 25 to 40%, and some studies say even 50%. And so if TKAs are again going to increase by 637% in 20 years, then that would mean that within 20 years' time, we'll be doing 3 times the number of partial knees than we currently do of total knees, which would be 1.8 million people a year would receive a partial knee replacement in the United States. Now, this is speculative statistics about the future, but this is where the numbers are currently taking us. So what's the benefit of a partial knee replacement? Partial knee replacements have been studied very well. They're not as large of series as total knee replacements because we haven't done as many of them, but there are a lot of good studies out there, and they show that most patients feel that the partial knee replacement gives them a more normal joint. Okay? You say, well, what does that mean? Well, what it means is a total knee replacement is a mechanical knee joint. It's not the joint you were born with. It doesn't act like a normal joint. It clicks. It's non-painful clicking, but it clicks. Usually you get over it and you don't think about that anymore, but anyone with a total knee will tell you, oh, it'll click every now and then, or I can even make it click. Most people don't like to kneel on an artificial knee. That's another thing, you know. So it's not the knee you were born with. It's just supposed to be better than the knee that you had once your knee went bad. Okay? So when you say a partial knee feels more like your normal knee, that's because we're leaving 2/3 of the joint completely normal. 2/3 of the joint stay your normal joint, and we're only replacing the portion of the knee that is most damaged by the disease process. So what I like to say to patients is, my goal here isn't to get rid of 100% of your pain. My goal is to get rid of 90+% of your pain, and if I did that, and you had the knee that you had 10 years ago and could go back to all the activities you were enjoying, would you be happy? And if they say yes to that, then I say, you know, we need to talk about partial knee replacement. If they say, you know, no, I want everything gone, I tell them, well, you can't have a surgery at all, because total knees have painful surgeries, or have painful knees afterwards too on occasion. Okay? So it feels like a more normal knee to patients. It is a less invasive procedure than a total knee. So comparatively, it's a less invasive procedure than a total knee. It's a smaller incision. You don't have to make as large of an incision into the quadriceps tendon. Okay? When you make an incision to do a knee replacement, you have to move that out of the way to get to the bone. So you don't have to make as large of an incision. There's been shown early functional recovery, so a little more rapid return to function. That would be intuitive to all of us. Greater range of motion and less stiffness. Well, if you think about it, if we're not replacing the entire knee, if we're only replacing the portion that is the most damaged, then the odds of us having a lot of scarring or a very inflamed knee afterwards is probably a little less with a partial knee than it is with a total knee. There's some bias in that data because I already told you that in order to do a total knee on you, you need to have functional range of motion. So if you have functional range of motion before surgery, you're probably going to have a little better than functional range of motion after surgery. And so to say that partial knee replacements always give greater range of motion than a total knee is not 100%. It's a little skewed by the data because the patients who receive it don't have as bad of a knee. Does that make sense?
Yes.
So other studies showing where the patients who have had both prefer their partial knee. Yes, sir.
Are there significant durability differences between like a full knee and a partial knee?
Durability in terms of how long they last?
Yes.
Yeah, we're going to get to that. Okay. That's coming up next. Less blood loss, smaller surgery, less invasive, less blood loss. Lower rate of infection has been shown. Smaller surgery, less exposure, lower rate of infection. Lower 5-year complication rate has been shown. There were 11% complication rate. This is all complications, all comers, whether it's a skin issue, a blood clot, a readmission for nausea and vomiting, just whatever the complication was about 11% for total knee replacements, 4.3% at 5 years. And then here's the other thing, outpatient surgery. With a partial knee replacement in a healthy person, outpatient surgery is a possibility because early function, less pain, smaller surgery, less blood loss, and other things we're going to talk about at the end of this lecture with our rapid recovery programs. Are there people doing outpatient total knees? There are some places in the United States doing outpatient total knees, and they are publishing on that, and they are having good results. I believe that there are more places probably doing partial knees. Now, partial knee is really set up to be a very good outpatient surgery. So, back to this gentleman's question. What's the negatives? What's the disadvantages? Does the partial knee arthroplasty have a higher failure rate? Okay. And it depends on the data that you look at, but I say yes at this time. And maybe 15 to 20 years from now, we'll say no, it's the same. But right now, I say yes. So if we just kind of lump all the data and just choose what we think is the most average number, we'll say a total knee lasts 20 years 90% of the time. And we'll say a partial knee lasts 15 years 85% of the time. Okay? Now, there is some bias in this data. You have to remember that any scientific data I give you is only as good as the data that was originally collected. So, in order to understand why there could be a potential for a partial knee replacement to fail more readily than a total knee replacement, we have to understand why they fail. So, this is why they fail. So, a partial knee replacement fails because the components loosen. That's also the main reason a total knee replacement fails. This is the key one. The partial knee replacement can fail because of pain or dissatisfaction. You won't see that on this list. Okay? We'll get back to that. The partial knee replacement can fail because you develop arthritis in another area of the joint where we didn't replace it. And that becomes so bad that you're no longer happy with your knee. Well, that can't happen to a total knee because the whole joint's replaced. And then wear of the components can also occur. So, pain and dissatisfaction. Depending on the studies you look at, 10 to 20% of patients who undergo a total knee replacement are dissatisfied with their knee. Okay? That's a significant number. And they're dissatisfied with their knee regardless of whether or not we can find an abnormality with their knee. Okay, so we do a bunch of the fanciest tests we can do. We run the test for infection. We check the alignment of the components. We CAT scan the knee. We're checking clinically, is it too stiff? Is it too loose? Is it laxed? Is there a fracture? You know, we check all of these things, and if we find nothing wrong, there's still about a 10%, and sometimes in some literature a 20% chance of a patient not being satisfied with their knee. If you're not satisfied with a total knee, and we can't find a reason wrong with it, then you live with your dissatisfaction. Because we can't tell you that changing this knee to a new, larger revision total knee will bring you the satisfaction that you desire. If you're dissatisfied with a partial knee replacement, you get to have a total knee replacement. Okay? So, a lot of people believe that this is the reason why those numbers are a little lower. Okay? I thought you were raising your hand and you're scratching your forehead. I'm sorry. Okay. I think I skipped a slide to talk about that. Okay, revision of a partial knee. So this is what we just mentioned. So the partial knee replacement is sometimes used as a, quote, staging procedure. So if you're a patient who's 45, let's say, and you have criteria that fits a partial knee replacement, then I would more than likely tell you that here's your risk and your benefits of a partial knee replacement. I recommend that you should probably undergo the surgery and that you'll most likely be very happy with it. And this partial knee replacement will probably last you somewhere between 15 to 20 years, depending on your activity level, depending on a range of things. And that when that 15 or 20 years are over, you're going to be somewhere between 60 to 65. You're most likely still alive, and we're going to have to revise you to a total knee replacement. Most data show that when you revise a partial knee replacement to a total knee replacement, it acts as if you had originally done a total knee replacement, meaning that it's not a worse surgery. It's still a good surgery. But that data is performed by joint specialists. It comes out of areas where people who focused on joints and did joints exclusively. And that does matter. It doesn't mean that community orthopedic surgeons aren't very good at this surgery. It just means that if you're a person who does 300 artificial joints a year, you're probably doing a little better job than someone who does 50. And then the other caveat is there can't be a lot of bone loss. If your components had loosened over time and there was a lot of bone loss, you might require more of a revision type prosthesis, which is more metal. So a basic understanding is remember that an orthopedic surgeon, bone is our material. Bone is our construction material. And if we don't have that, we have to replace it, and we usually replace it with metal. Yes, ma'am?
Your clinic also gives injections into the knee of artificial synovial fluid, Synvist, to postpone partial knee replacement. Can you speak about that?
Sure. So viscosupplementation. There is some data talking about how when arthritis sets in, the consistency and the makeup of the synovial fluid changes. And there's some belief that if you try to put the synovial fluid back into its normal composition, then you might be able to allow better nutrition to the articular cartilage, because the articular cartilage does not have blood flow. It receives its nutrition through dissipation of the fluid in the knee. And so we do the viscosupplementation for that reason. The viscosupplementation does not have good data that it works well. It is one of the things where you discuss it with a patient and you tell them that we have some patients that when they undergo it, they really feel a lot of relief. They really, and they get their surgery date prolonged away, right? We will talk again if you start having pain again. But the American Academy of Orthopedic Surgeons, which is our kind of governing, it's not a governance board, but it's a board that we all join, and we try to come up with basic understandings of how we should all be practicing orthopedic surgery. They currently do not say that they recommend viscosupplementation, okay? Because there's not a lot of great data showing that it works extremely well. There was animal data is what it was originally based on. We started with, I think it was a dog study and possibly a large animal study with arthritis, and they watched the dogs and they watched what they're capable of doing afterwards before we go to clinical trials, and there was improvement in the animals. And animals, we think, don't have a placebo effect, and so it was felt that this might help humans, and so we started, maybe they do, maybe they want to please us and they'll be like, oh, it helped, thanks. But, so we started doing it in humans. And I have patients who, when you perform that injection for them, they do feel like it works. I have plenty of patients who say it doesn't. Okay. Yes, sir. We're going to press on. Okay, sorry. My time is running short. So let's accelerate through the accelerated recovery programs here. So this is what we're talking about when we're talking about possible future of arthroplasty being more on an outpatient basis. And what it is it is a team approach to your care. It talks about rehabilitation, education of the patient so you know what to expect, so you're empowered and you get rid of your fear and anxiety for these things. Pain management, regional pain management, particularly spinals or injections in the peripheral nerves to really control pain, not just shoving people full of narcotics, which causes nausea and constipation and vomiting, etc., and just saying we're going to dull your pain. Instead, we try to blockade the pain, and we try to block it at several places. And then combine this with our less invasive surgical approaches, which might be the least important, honestly. It could be that this pain management and this rehabilitation and education is the most important thing for patients. So all these things kind of come together is non-narcotic driven, the multimodal pain care, and this we avoid the side effects and we do early rehabilitation. These are our enemies to recovery. Dependence is our biggest enemy to recovery. Patients feel, well, I was independent, now I'm going to be dependent, I've just had a surgery. So what do we have to do is we get them up with physical therapy the day of surgery and we show them early mobilization equals independence. You can do these things. You might be doing them a little slower till you heal, but you can do them. Poor patient motivation, how do we fix that? We educate you. We educate you before surgery. We educate you with the physical therapist. The doctor educates you. We go to a joint class. We do all these things before, and we make you feel empowered that you know what to expect and you know what's going on if you have a side effect. Pain management, we discussed. Blood loss, we're working on new techniques to do everything we can to decrease our blood loss so that we don't require transfusions and we don't have complications from that. So here's our criteria for discharge home, and that's pretty standard stuff. So what's wrong with staying in a hospital too long or going to an inpatient rehab? There's nothing wrong with it. There's nothing wrong with it as long as you medically need it. If you don't medically need it, then you shouldn't be there. If you meet the criteria for discharge from an inpatient facility, then you should go home. Why should you go home? Because you avoid exposure to hospital-acquired infections. You decrease your self-reliance as you sit in a hospital and have people do things for you. Sleep deprivation. New data showing how patients don't sleep in hospitals at all. They're up all night. There's bells, there's whistles. It's in a different place. There's vital signs. And then other variables can be introduced, such as you go to a rehab facility, there's a doctor there, they're managing your INR instead of me. They put it at a different level, you develop a hematoma or a big bleeding problem. Or they decide to treat you with narcotics when we were doing really good with not treating you with narcotics by giving you anti-inflammatory. So your care gets broken apart and you get taken off the protocol. And the truth is, patients don't want to stay in hospitals. They're just scared to go home. And so it's just the anxiety that you're treating. You want to educate them and make them feel like they can do these things. So the future is outpatient joint surgery, and it is here. We're not currently doing it at Vanderbilt, but that's what I'm working on. So. Sorry I ran over.
Let's try to be back very promptly in about 8 to 10 minutes.